Yes.
Mm. On, everyone. Are you there? Lemis, Khidir? No? Ibrahim? Barra?
Yes.
No one there? Abdulaziz? Dua? Arwa? Arwa Mustafa? Bashar? No? Are you connected?
Yes, I'm connected.
Huh?
أيوة connected.
Speak up. Speak out. Hello?
Yes.
يا دكتور سامعيننا كويس you can start.
سامعين كويس. طيب, very good, and thank you for joining me again in this fixed lecture on tropical diseases. Time passes by very quickly, and I hope you will benefit from these lectures because the way I tried to give it is in a simple way. I know tropical disease is not easy, especially with all these names, vector names, disease names, worms, and so on. But I meant to make it simpler, especially with ideas which are essential for you to further read if you have time, or at least when you graduate and become consultant, at least you will have the basis of tropical diseases, which is very important. I would like just to roam around on some of the uh, ideas and some of the knowledge which we have been discussing in the last 6 weeks. And then we will go into our lecture today, which is Loa Loa. Loa Loa is another filarial disease, which has some importance, and we'll discuss that. But you remember, we always talk about a disease, a vector, a diseased person, and a healthy person. So this is a circle which we call a vicious circle or bad circle that continues to perpetuate the transmission of the disease. And you remember we talked about how to break the disease, and that is how to control the disease. If we break the circle, we control the disease. So wherever it is weak, then if you attack it, the breaks the cycle, and then you control the disease. Like if you're talking about onchocerciasis, the flies, the simulium, the black fly, if you attack the fly like what OCP, which is Onchocerciasis Control Program of West Africa, has done, then you reduce the disease because you break the cycle. And if you treat the parasite in the diseased patients, like what we did with ivermectin in Africa, then again you break the cycle. So it is important for you to at least conceive, all right, or formulate an idea about the transmission of the disease. When we talk about epidemiology of the disease, what are the factors which facilitate the presence of the disease? What are the factors which will propagate and increase transmission? What are the factors which will hinder the progress of the disease? And then what is the treatment of that disease? So these are the areas. The word vector, you should remember, is this is the fly which uh, transmits the disease. And here the word transmit is uh, the weak word, the soft word, because here the vector, what we diagnose the vector as an insect which develop the parasite. It's not a vector, it's not a mechanical vector, it is an actual vector whereby larva 1, which is being taken from the diseased patient to the vector, it develops and becomes, to the time it reaches the thoracic region of the fly, it becomes from changing from larva 1, which usually is the one caught from the diseased patient, to larva 3, which is the infective form of the disease, which can be re-injected in a healthy person. So the vector is a fly, all right, or an insect, better insect, which helps and perpetuate the infection by developing the parasite more. We had a mechanical vector. Okay, that is not what we say about the vector. Mechanical vector is like housefly. Housefly, if it lands in a feces, okay, of a human being who had hepatitis A, then it takes part of the feces, and then when it land on a food, if you are not careful, then you eat what the fly has landed with, and then you get infection, what we call fecal-oral transmission. So that is mechanical, and you may do it even without fly. You can do it with a hand. If you're not clean, you don't clean yourself. You have the residue of some of the feces, and then it rubs on the food that will cause infection. So the vector is important. Then the parasite. I would like you to think about these vectors, okay? How they behave. They're so different. Okay, the Papatasi or the Simulium, uh, the Philippopotamus Papatasi, you remember, is the vector for Calazar, Philippopotamus Papatasi. You remember it's a weak vector that can't fly more than 2 meters. It's weak for traveling. It's lazy, just is in the savanna acacia area, acacia trees, and in the furrows of the mud or furrows in the land. So it keeps itself there. It doesn't move a lot. While you have a fly, which is called Simulium damnosum of onchocerciasis, and this is a very active fly. It's 1/4 size of a house fly, but it is very active. It flies up to 500 kilometers in with the wind. So it is a very determined fly. So, and there are other flies which we are going to see are living in the forest, like chrysops of the lower lower. So, and Simulium lives in fresh water, in the rocks, under the fresh water where an oxygen environment has been created. So think, why are these flies, so to speak, so different? And what makes the fly peculiar to the parasite? So if you get a simulium fly and bites a human being and get the blood of Talazar, which is the Donovan body, will it take it? It will not take it. So there is a reason. There is something which embedded and inbred in the flies, which makes it the vector of that particular parasite. Okay, the parasite itself is very peculiar. If you just take the family of filariasis or filarial disease, you remember we have talked about onchocerciasis, which is the filarial disease, and we have talked about the classical filarial disease, which is lymphatic filariasis, and then we talk about lower lower, and these flies have peculiar way and peculiar living conditions in the body. Onchocerciasis only limits itself to the skin and maybe the eye. It doesn't go inside, it doesn't go in the blood, cannot be recovered from the blood. So if it is in the blood, it's ectopic. So what makes it just limit itself to here, all right, and to the nodule of the other worm, which is found in the pelvis or around the pelvis. Okay, all the day, if you take a skinny snip, a small skinny snip, even with a clean razor, and then put it in saline, and then rub it with a needle, and then look under the microscope, you can see the wriggling microflarea. It doesn't go anywhere apart from the skin. Look at lymphatic filariasis, which is Washeria bancrofti, okay, or Brugia malaya. These are the parasite, the adult worm of which cause obstruction of the lymphatic vessels and lead to elephantiasis or swelling of the leg or the arm or the breast in a form of non-pitting edema, and then in a form of leading to corrugation of the skin, dermatitis, fissuring, and huge leg, just like the elephant skin and elephant leg. So this is the adult form. While in onchocerciasis, what causes the harm is the microflarea. Okay, so why is that? Why is that? This is a microflarea which damages, and there it is the other worm which is damages. That is another peculiar thing. I'm giving you points to think about so that treatment can be constructed and breaking the cycle can be thought of. You remember we talked about endo symbiotic, into symbiosis. And symbiosis is two creatures or two organisms that live together, not only in harmony, but dependent on each other for survival or viability, because they may feed each other with enzymes, with cytokines, with something which is, vital for each other. And you remember the onchocerciasis, we talked about Wolbachia. Wolbachia, this is a rod bacteria which is within the parasite. It lives dependent on the parasite, which is Onchocerca volvos, and the parasite depends on it, to the extent that if you use doxycycline, which kills the Wolbachia, you get 60% of death on the parasite. And actually, embryogenesis will stop. So this is a bacterium. And people found this is a way to kill the parasite, because if you kill the brother of the parasite, you may kill the parasite itself. So this is why we are using doxycycline, and at the end of the day, we kill the parasite. Are you with me still? Are you there?
Yes.
Okay. So these are some points. Again, the appearance of microflarea in the blood. Appearance of microflarea in the blood. In onchocerciasis, if you take a skin snip any time of the day, you find the microflarea. So the microflarea is living happily within the skin all day long. But look at lymphatic filariasis. Lymphatic filariasis, the filarial microflarea lives in the blood. The adult worm lives in the lymphatics, but the microflarea appears when sun sets. When the sun goes down and the night starts, the microflarea starts to appear. Where is this microflarea living or disappearing during the day? And it reaches the maximum by midnight. That's lymphatic filariasis. Okay, microflora or Sharia Bancrofti, midnight, if you wake the patient up and you take a snip, no, sorry, you take a sample of blood, then you look under the Gims stain, then you find abundance of the parasite or microflora. While in Loa Loa, for instance, the appearance of the microflora in the blood is only during the day. And that determines the activity of the vector. The mosquito, which is the Anopheles or Culex, which is the vector of the lymphatic filariasis, is an urban as well as rural. So they live in water, like stocks of water, like barrels, or even the static tires with water abandoned. They live there in the urban area. So, and they feed on the parasite, okay, and they disseminate it. Okay, but then if you come to the evening, they bite. They bite. They rest during the day and they bite during the night. It's peculiar because that is the time when the parasite in the blood appears. So it bites at the time when the parasite, and this is nature to keep it living. Every organism finds a way to live, and that is the important thing. Then the other part, which I want to roam around like siyaha, is the treatment. Okay, we have to confess that these diseases are devastating. These are chronic diseases. Chronic diseases. Just imagine that if you are bitten by a Simulium damnosa today, which carries onchocerciasis, you will have an appearance of symptoms of clinical picture in 1 year. In 1 year. So it takes time. And then the production of the microfilariae to show the disease takes slow. You remember the adult worm lives 15 years in the body, so it's a very chronic disease. Lymphatic filariasis, if you don't live in an area, okay, you get repeated infection from childhood, one single dose, one single infection, two single infection, visitors will not be affected by lymphatic filariasis. So it needs a continuous injection of microfilariae, okay? So it's are very chronic diseases, extremely chronic. Their cycle is chronic, and that has to be borne in mind. Once the disease establishes in a human body, then that human body is affected chronically and devastatingly. If you get a big lead, then your life becomes miserable. If you get a big hydrocele, and you have seen in the pictures that some hydroceles are, heavier than the human body, but and if you get blindness, that you had it, that is life. So these chronic diseases are chronic in the nature of pathogenesis and pathology, and in treatment they don't disappear overnight. Some of them would have made permanent damage, like lymphatic filariasis. If the lymphatics are being damaged, then no treatment, no even surgical treatment will rescue these vessels. So it's important to prevent the diseases. And the beauty about tropical diseases these days is the advanced development of drugs. You remember in the first lecture I said, well, if you know 4 drugs for tropical diseases, then you are home and dry. Home and dry, you can deal with a lot of disease. Ivermectin is what we call the wonder drug. Ivermectin, which is mectizan, this is used mainly for onchocerciasis, but also used for lymphatic filariasis with albendazole. And when you give these drugs, the two of them, or even ivermectin alone, you get collateral benefits. The collateral here is you treat roundworms, okay? You treat ankylostoma, okay? So that is an offshoot of the treatment of onchocerciasis. And if you add albendazole, like in areas where we mass distribute albendazole and ivermectin, then you get benefits of not only the worms, but even the Loa Loa, which we are going to talk about, will be decreased in intensity because both albendazole and ivermectin are the drug of choice for Loa Loa. So with one stone, maybe 2 stones, albendazole and ivermectin, if you distribute mass in a village or an area, then you get out with a lot of benefits. This is why we are seeing less and less of the tropical disease, except in areas where there is conflict, the health cadre cannot go in and treat. But in areas which are stable, then that is what is happening today. And if you add our friend praziquantel, which is the choice treatment of schistosomiasis, then you treat almost 80% or 90% of the tropical diseases. So please think about the vector, about the habitat, about the nature of the fly or the nature of the vector or the insect. Think about the disease, peculiarity of the disease, disease in the body, what does it do in pathology, and in terms of uh, interruption of transmission, you also need to think about prevention, prevent the healthy people from getting the disease. And here there is a problem. The problem is some of these diseases, human beings do not show pathology. They do not show pathology. And one of them is, as we said last time, is Washeria bancrofti, which is lymphatic filariasis. So you can harbor microflaria for years, but showing no disease. And this act as reservoirs. Okay, the disease transmission will continue because some of them never complain and they become like a reservoir of that disease. Why do people harbor the infection but don't show the disease? Is it immunity? Is it the type of the parasite? Is it something else we don't know? You always try to think beyond the box, outside the box, and then this is what we call critical mind and research mind. There are the drugs, despite the fact that they are very good, ivermectin, there is newer drugs. Why? Why do carry newer drugs? Because of fear of resistance. Okay, at one time, people were talking about resistance to ivermectin. Luckily, it is a very short scale. People are talking about praziquantel, resistance to praziquantel. So since schistosomiasis, there is only one drug now, not only drug of choice, but almost the only drug which is available for us to treat schistosomiasis. If we lose it, we are in a big problem. So this is why researchers continue to search for newer drugs in tropical diseases, lest we get resistance to our novel drugs which are available. Okay, this is why I'm introducing a drug called moxidectin. Moxidectin. Moxidectin, it is Moxidectin. Moxidectin. And I have the pleasure of being the chairman of development of that drug in WHO. And actually, it has been fought. People fought against that drug. I don't know. It must be commercial. But the committee carried on. The drug companies, the people has to change the drug company to another drug company. And then they took it, an Australian drug company took it and developed it. Now it is a very good drug, safe, and it stands as an alternative and maybe stronger than ivermectin. But at least since ivermectin is known to us, since it is free, there is no reason to change. But I will tell you in Loa Loa, there is certain areas where if we use moxidectin, it is rapid on onset and it kills more microfilaria dose to dose with ivermectin. So in that sense, if you give moxidectin faster, elimination can occur. So that is about the drugs. So get from what I say is the salient features, salient information which you need to carry on with tropical disease. Okay, today we're going to talk about uh, some of the important aspects of diagnosis. Diagnosis in tropical diseases depend on the golden standard. The golden standard and the proof of the pudding is in finding the microflaria either in the skin, in the body, in the blood, or whatever. So that is important. That is the golden standard. But you have to remember that there are now serological tests, which is antigen like filarial circulating antigen. And this is chromatographic or immunochromatographic. And there is now tests, just like the ICT for malaria. You just go there, it's serology, it gives you a positive or a negative. This is why you have a CAR test for lymphatic filariasis. Okay. I'd like to talk about eosinophilia. In eosinophilia is part of the white cell count. And you remember one of the functions of white cell count is to combat infections. Okay? The combat infection. It's a soldier, it's a Kalashnikov of the body to kill the bacteria. So it engulfed it, and during that, it even dies and forms pus. Okay, so eosinophilia has been rethought as a part of the leukocyte, which has an immunological activity. It has a immunological activity. So it's now found, in patients with hematobium infection. People has been staining for eosinophils in the urine, and it has been found it attacks the eggs of the hematobium. There is one syndrome which occurs in lymphatic filariasis, that is in eosinophilic reaction in the lungs. The worm, lymphatic filariasis worms, when circulate within the body, they are killed mainly by eosinophils in the lungs. And the patient develops a syndrome similar to Loeffler's, Loef, Loeffler syndrome. This is an allergic syndrome whereby the body or the lungs react with hypersensitivity. And here, with lymphatic filariasis, it causes eosinophilic death caused by the eosinophils for the microflaria. It causes damage to the lung. It causes alveolar damage. The patient presents with fever, presents with wheezing sounds, rhonchi, and maybe later develops cough and periodontitis sputum. So the role of eosinophils is diagnostic, which is important, and most of the parasites, if you examine the white cells, you get high eosinophil count. So this is something you remember when you are diagnosing a parasite, all right, in the body, because the eosinophils are not a marker. We think that the eosinophils are now killing cells for these parasites. Okay, then we go to Loa Loa. This is a filarial infection. You remember when we talked about filariasis, these are group of nematodes. And nematodes are round worms, which are either luminal, like intestinal, gastrointestinal, or tissue worms. The tissue worms, like what we say, the crisis, which is a tissue worm, onco is a tissue worm, guinea worm, which is dragon worm, okay? Lower is another tissue worm. But if you talk about ascaris, hookworm, these are nematodes which are intestinal or what we call luminal intestinal worms. So the tissue worms are more difficult to treat because here the body reacts with a lot of immunity. And as we have seen in onchocerciasis, the immunity mounted by the body, okay, the greater that immunity, the more symptoms you will get. And on onchocerciasis, the disease is brought about by dead microflaria because then the body will be attacking the parasite, the dead parasite, and then create inflammatory cells and the sequelae of what you know from the physical science of onchocerciasis. Okay, then another filarial is Loa Loa. Loa Loa is what is called African eyewear. African eyewear. And in Africa, it's only known in Africa. In Africa, in the forest region, Cameroon, DRC, and the highest level of DRC, Democratic Republic of Congo, Angola, and Equatorial Guinea, and even in South Sudan, Lower Lower can be found. It is a filarial. The adult worm is about 5-6 centimeters, and the poor male always is half the size or less of that half size. It's about 2-3 centimeters. But the female of onchocerciasis is the real queen because it measures 70 centimeters while the male measures about 4 centimeters. So this is a variety, but we have seen in all parasites that the female, which takes a lot of burden of producing microfilariae, is big, and maybe it needs that volume to produce microfilariae. So Loa Loa is called the worm, the African eye worm. So if you remember from Loa Loa, as far as symptoms are concerned, two signs. Sign one is that the worm, the adult worm, goes under the conjunctiva, the bulbar conjunctiva, and it can be seen. It can be seen. And people would look at you and say, well, there is a streak there, which is hard, and that is the worm. Luckily, it traverses, goes out, and it causes itching, urticaria in the eye, watering, lacrimation, and it rests there for a few days and then passes out. The unlucky, rare eye will get the worm penetrating the eye and causing ophthalmic infection. And here, if it goes in, the body will react. White cells, eosinophils, whatever, and then the reaction will do the damage of the cells, and the eye may be lost completely and become blind. But this is with Loa Loa is rare. Okay. So the other physical sign is areas big like urticaria. It is about 6 centimeters, 4 to 6 centimeters, rounded, raised, and itchy, but stays a few days and then passes away to another area. This is what we call Calabar swelling. Calabar swelling. And Calabar is the capital city of a state in Nigeria. This is where this is the first symptomatology was described. It is in Nigeria, Calabar, Cross River. The state is Cross River. So the Calabar swelling can appear in any area, but mostly in the eye, in the hand, in the wrist, in the lower arm, and some of the legs, the Calabar. So, but these are fleeting. It goes from area to area, but disappears. When it disappears, it leaves no residue. But once it raises there, it becomes, very itchy. It becomes even with some pain, and very rarely you can get fever, but usually it passes without any hindrance. So these are the two signs of Loa Loa. Otherwise, Loa Loa doesn't cause a lot of harm, except when in high intensity in the blood, more than 30,000 per cubic micromil in patients with co-infection with onchocerciasis. Okay, what happens? If you give ivermectin in normal cases, no onchocerciasis for patients Loa Loa, it helps, it kills the worm. Okay, so if the patient is given for ivermectin for onchocerciasis but unfortunately has also a co-infection of lower lower at a very high level, then problems occur. What are these problems? Problem number one, these worms can go to the brain and they can cause this drug killing, mass killing of lower lower in the brain, causes very severe encephalitis or encephalitis. It causes bleeding in the conjunctiva, maybe inside in the retina, and the patient will be in coma, and this may occur. So, what we advise in treatment of onchocerciasis is that we have to know the area of heavy infection with lower lung. And this is luckily we can do it. Okay, so it is important to remember that severe encephalitis with ivermectin occurs if there is high infection with lower lung. Okay, then the eye in the worm in the eye, okay, is being used as an indicator of presence of lower or otherwise. Because if I want to go and treat onchocerciasis, and then I fear that there is a case of lower lower, we have what we call RAP lower, RAP from rapid lower test. This is what we do. This is clinical. It's just taking number of subjects in the village and to see who have witnessed in another patient the worm in the eye. And this has been found to be a very good proxy to the endemicity of lava. So if it is a level of, say, 40% people have seen these worms, then this area may be a high endemicity of lower lava, and you have to be very careful with ivermectin in treatment of onchocerciasis. Here, we give albendazole, and albendazole may kill some of the adult worms, reducing the microflare. Because if you have a low level of lower lower or medium level with ivermectin, you don't get problem. You only get problem in those who have ivermectin, who are given ivermectin or onchocerciasis with high level of lower lower. So that is important. But people have died. People have died in Cameroon and with ivermectin due to invasion of lower in the brain, causing encephalitis. And that has really raised the alarm very high and has a setback of treatment with ivermectin. But luckily, with the RAP lower, then now people knew which area to abstain from treatment and give first albendazole and then give ivermectin. So it's this brings us to obviously we talked about the xenophilia, and would like to talk about what is called the larval migrants. And larva migrants is sometimes you see a migration under the skin of a worm. And this worm, can go from under the skin to another area. So migrants from migrating from one area to another area. And there are a number of worms which will do this, not only lower because it migrates, but you have strongyloides, styrocoralis. This is a worm, it's intestinal worm, but can travel within the body to cause larval migrants. And I have seen with Dr. Martazim, he showed me a picture that a student from 26 have photographed a patient who has a migrating worm under the axilla, which was a very beautiful picture as far as the picture. But I'm sure the patient would have felt severe pain with that migrating worms. Apart from strongyloides, there are other which can also travel. Manusella, perstans, and there is another one called Spargognosis. So if you remember Loa Loa, if you remember strong Loiasis, these are good enough to remember. But other words are some areas, especially in Southeast Asia, there are worms which can migrate. Okay, the fly, the vector of Loa Loa, it is called Chrysops, Chrysops, Chrysops. These are flies or insects which are only found in forest. So this is why Loa Loa is a disease of people living in the forest. Okay. Chrysops is a very efficient vector. It lives on plants in muddy water, in the plants in the muddy water. And once they throw the eggs go down in the mud and takes almost 1 year to develop into larvae. Okay. And then larvae obviously will grow into more flies. Okay. So it's chrysops and it's a day biter because Loa, as we said, appears in the blood during the day. So the chrysops appears during the day and bite and transmits the disease. Okay, so it's that is the Loa, and luckily with the treatment of ivermectin in for onchocerciasis, which is a huge campaign, a huge program, then other worms are being treated as well. Okay, if you add both albendazole and ivermectin in areas with lymphatic filariasis, then you get the benefit of the two drugs. Okay, certain parasites will affect the heart. Certain parasites will affect the heart. Okay, Loa can affect the heart. Loa can affect the kidneys, but rare, but very rare. But we know of quite a number of parasites that can invade the heart and do damage to the endothelium of the heart. Okay, then we will talk about the control of the vector. Because of the fast of the nature of the forest, control is not easy because this is a vast area. Transport and movement of people and cars is very difficult. So Chrysops has not been tried to be controlled. Okay, but with ivermectin, then we break the cycle at the level of the patients. Okay, are there any questions? I think we are not getting interaction, so we hope that some questions will come out. At least it will give me some indication that you are still uh, there and you are still awake.
Thank you so much, Doctor, for this very informative session. It's really interesting to learn about neglected tropical disease and these issues. I want to ask about the drug that you've been talking about, the moxitidine. I'm doing my
Moxidectin.
research on moxidectin, sorry. So,
Yes.
yes, I'm doing my research on the soil transmitted helminth intestinal worms
Yes.
here in Rwanda because it's the most
Yes.
prevalent neglected tropical disease. And I'm trying to study the relationship between it and the stunting levels because it's also a major health problem here. And
Yeah.
I'm going to look the data from the Rwanda Biomedical Center because they are doing a study on, they're trying to reduce the intensity of the infection as they're having like kind of a deadline with the WHO. So they're trying to study different modalities of treatment using albendazole and ivermectin. But they're going like to changing the how many times they do the deworming and so. So I want to ask if this can be used as a modality of treatment? Like, can it be like RCT or something, or it's not allowed to do it for humans for this disease?
No, the drug has been tested for over 7, 8 years. Now the drug is very safe. Moxidectin, moxidectin, Tectin, moxidectin. This is a second line drug. Because up to now, ivermectin and albendazole are the best, very well tolerated, and they have very high efficiency. So we're not using moxidectin. I mentioned moxidectin because in areas with lower, ivermectin alone will cause encephalitis if the patient also has high infection with lower. And in this area, we can use moxidectin. It has not been reported to have encephalitis. And since ivermectin is available, since ivermectin is a good drug with very less effects, since it is being donated free, then with albendazole, which is also donated free, why should we bother? Leave moxidectin as a second-line drug, or in areas where we want a very quick elimination, or areas with low. So that is very important question. And I think your research is very timely and very good. I have Arwa with me here, and she nods, saying yes, that is a very good research because it ties up to the need of the country. So that is important. So read about intestinal worms, and we're going to talk about intestinal worms at length in these lectures. But it is a disease of children which causes stunting of growth and cognitive impairment. Cognitive meaning learning impairment. Any questions? Abir Yusuf, are you there? Dua Taib, they don't say yes. They are not either there or they don't want to talk. Istifa,
نعم يا دكتور.
Istifa Khorshid,
أيوة.
you doing okay?
Yes, I'm doing good. I was talking about my research just now.
Yes. What is it?
The soil transmitted in helminth and its relationship with the stenting. This was me.
This is you, I see. This is Istifa. Okay.
Yes.
Khalid Walid. Is he there? Khalid? Any Khalid? Awab? Not there? They went to sleep, huh? Do you remember diethyl carbamazine? Anyone? Diethyl carbamazine, DEC, yes? Who is speaking?
أنا نصر الله.
Aywa. What is DEC?
It's a very potent, it's a flaricidal drug. It will cause blindness if used to treat onchocerciasis.
Yes. So what does it do? Saying if I give it to a patient with onchocerciasis, what does it do and why ivermectin will not do that?
Because as I said, it's a very potent flaricidal medication. It will kill the filaria in the eyes.
Yes.
It will induce an inflammatory action resulting in blindness.
Yes.
While ivermectin will treat the disease, but it's less potent than diethyl carbamazine. It will not cause blindness.
Yeah, and it causes the filaria or the oncocer microflaria to go outside the eye. That is the beauty. It goes outside the eye before it kills it. So somehow it doesn't kill it within the eye. This is why it spares the eye from blindness. Diethyl carbamazine is very heavy, strong, and it kills the microfilariae in the eye. This is why it is. But DEC is a very, very potent antifilarial, okay? In still used in areas where there is no onco. It's used in lymphatic filariasis in where? In which area? We use it for lymphatic filariasis, and I talked about even the drug being tasteless and it is stable in boiling. It can be even used in
India, I think. In
in
India.
yes,
India.
India, yes. And how can we distribute it in mass?
I think the Indians were very clever to fortify the salt with the medication since
Yes,
it's tasteless. So they ensure great distribution of the medication to the population.
very good. That is it. And it should. The distribution of the salt DEC showed that it is very effective in elimination of filariasis. Okay, for Loa, again, DEC is very strong and it can be given. But again, it is in Africa where onchocerciasis may be there, so DEC is not now used for any other parasite in Africa. It's only in areas where there is no onchocerciasis. Peculiarly, Kenya. Kenya is spared from onchocerciasis. I don't know why. But it has LF, lymphatic filariasis. And maybe this is a single country where everybody is using D and okay. So this is one area. But generally in Africa, where there's onchocerciasis, we don't use DEC. So that is the answer to the question. Okay, we need another question. Anyone? Ruba Ahmed.
Yes.
Any questions? Yes. What is your research?
I'm not in batch 25.
You are in 27.
Yes.
Okay. What do you think? I mean, are you interested in a tropical topic, or do you have an idea of what you should research? Because this is the time you should start. All 27 the students should get engaged in thinking about their project. The earlier you think about your research project, the better. You think about it better, you get a good proposal, and you can do it well because of the time allowed. And then you can write very good. And if you finish, you can even write a paper before submitting the thesis. And if you submit a paper, okay, you don't need to submit a thesis. You get good mark even with the thesis. And Arwa listening to me here, because the paper is the end result of a thesis. So please think about it earlier. Muhammad Nimir, Muhammad Nimir, is he there? Transfer student. Muhammad. Okay. Okay, so it's this maybe bring us to the last part of this lecture, and I would just like to remind you that these lectures will be, inshallah, handed on. It's all recorded, isn't it, Arwa? It's all recorded, but it's made simple, and the simplicity didn't come from me only, but it came from the fact that now we know exactly what are the factors that influence transmission of tropical diseases. And now we know what are the drugs which can be safely used in individual patients and in mass chemotherapy. Okay, would somebody tell me, maybe a class 16 to 2116, if a class will tell me what is the difference between control as a health problem, elimination, and eradication. These are terminology in public health which are very important. Anyone?
I can answer. Eradication
Yes,
is
yes, please.
yes, eradication when you finally have like zero incidence cases worldwide, like it's a global thing, and there's only I
And
think
which,
one disease that is
yes,
eradicated is the smallpox, and
yes, very good.
yeah, and then for the elimination, it is the I cannot use the word eradication, but just to simplify it, as if you just eradicate this disease from a specific geographical area or a country, for example.
Elimination is the absence of the disease in a certain specific area where it goes down to a level which is not viable for transmission. The parasite
Yes.
may be still there, but the transmission has been interrupted. So elimination is an area whereby the transmission has been interrupted. This cycle, which I described, is now open. It's the number of parasites in the body of individuals in the society is so little that the fly cannot feed and distribute it. Okay, so very good. You're doing very well. So it is elimination per area or per country whereby transmission of the disease has been eliminated or controlled. Okay, the third one is control.
بس الكلمة بتاعت interrupted دي يا جماعة 20 خط أحمر تحتها يكون في interruption للtransmission. آخر
Yes.
حاجة الcontrol is when you reduce the infection to a way that like it's acceptable. There is a transmission, but it's very minimal.
Okay, so
like
it's not charging the health system.
exactly.
مش كده؟ And
أيوة.
it's not a worry in the health system. It is there, but not as a worry. Control as a public health problem. Okay, that's very good. Very good. Okay, that is extremely good. So, what is preventive chemotherapy? مؤيد محمد النيل.
يا بروف هناك
مرحبا.
preventive هناك chemotherapy when you give a mass هناك chemotherapy for all the
mass
population of the specific area.
Yes. That's good. Give us more. I mean, you give it for the whole population. Okay, what are the criteria? What are the disease? How would you make sure that you are not giving it over? And then what are the control? So give us more about mass chemotherapy, preventive therapy. I could say mass chemotherapy, but when I say preventive chemotherapy, it's something which is more refined than just mass. Mass is mass. But when I say preventive, I'm using the criteria, the good criteria for selecting the area for mass, because I cannot go to an area where the disease is only 10% or 7% goes into the drug. That is not the way. So there is an area. Okay. And then those who are being taken away from the mass chemotherapy. Okay. مؤيد قول لسه.
يا بروف والله ده هنا مذكر.
طيب إن إحنا قلنا we don't use mass chemotherapy except if you reach a threshold. صح ولا ما صح؟ threshold. يعني في onchocerciasis we divided the regions into three. One is hypo, we don't worry about it. Then meso, and then hyper. As you go away from the river, onchocerciasis is about a disease around the river. So if you go around the river, then you reach the no problem. But in the middle, it is moderate problem, and here it is hyper problem. And there is landmark, there is threshold. If you reach 40%, say, of the population having nodules, then you have to treat mass. So mass chemotherapy or preventive chemotherapy is using the drug for every individual in the village, apart from those who are being contraindicated to the use of the drug. Okay? Then you give everybody. So the coverage rate of the population should be about 82 or more, because never 100%. Because there are pregnant ladies which you don't give. In onchocerciasis, ivermectin is not, we has no data about those who are below 5, and anyway, children with 5 up to 5, we don't know if there is disease, which worries us. So that is, you have to determine the level, and we use the rapid epidemiological mapping. In onchocerciasis, the rapid epidemiological mapping is the feeling of the nodules around the pelvis or the ribs. If you have one nodule, you are positive. Out of the 50, we take 50 individuals, and then we see how many. If there are 10, this is 20%. If it is 50, it is 100%. Okay, so that is the level. Determine the level. In Loa Loa, there is RAP Loa, which I told you about. This is a quick test. It's just questionnaire. All right. For lymphatic filariasis, it is hydrocele. You just go and examine for hydrocele, and you get a level, again, maybe 40 or less. Then you can say this area is eligible for mass chemotherapy. Okay, so that is preventive chemotherapy. And you use the drugs which we have outlined before. For onchocerciasis, ivermectin. For lymphatic filariasis, ivermectin and albendazole. For lymphatic filariasis in India, it is DEC, diethylcarbamazine, with ivermectin, and maybe albendazole as well. So to have a rapid elimination. And then when we talk about schistosomiasis, it is praziquantel. And we have tested that in Jazeera area. We have given drugs mass in an attempt. It was an experimental study in attempt to reduce morbidity. So that is as far as mass chemotherapy is concerned. Okay. Any questions? Sama? اسمك مكتوب لكن ما قدرت تنظم. سما؟ سلمى بكري بيلبس ولا ريم ساتي ريم جنبه ريم منه ما قدرت تتكلم ولا بس سجلت ومشت. Okay, anyway, this is about filariasis, and I think maybe that will go into another topic, intestinal worms or something like that. But we have still important diseases in tropical medicine which need to be discussed. With that, I would like to close, and thank you very much indeed for your company. Bye. Okay. Leave.